Hello and welcome back to Hypercalcemia for Health Sciences. In today's video, we shall discuss hypercalcemia from causes other than primary hyperparathyroidism and cancer. In the last video, we discussed the two major causes of hypercalcemia. We are talking about non-genetic causes. So these two include primary hyperparathyroidism, which is mediated by parathyroid hormone, and cancer, which is non-PTH mediated. In today's video, we shall look at some of the other causes of hypercalcemia. Let us first look at tertiary hyperparathyroidism, which is often due to chronic kidney disease. Now, the pathophysiology of hypercalcemia in chronic kidney disease is very complex because it may involve many different biomolecules as well as mechanisms. For example, when the kidney is not functioning for a long time, a lot of chemicals accumulate in the bloodstream. Some of these may be uremic toxins such as indoxyl sulfate, urea, creatinine, paracresol peptides, as well as several other chemicals. And these chemicals may interfere with the metabolism of vitamin D or the action of vitamin D. And they may also cause skeletal resistance to parathyroid hormone, as well as directly inhibit bone metabolism. In addition, when the kidney is impaired over long periods of time, remember the kidney is the place where calcitriol is produced. So this is going to affect the calcitriol production in the proximal tubular cells in the kidney. And then there are the uremic toxins that can also interfere with the production of calcitriol. Impaired kidney function will also affect the excretion of phosphate, and that may lead to high levels of phosphate in the bloodstream, or what we call hyperphosphatemia. This decreased calcitriol as well as increased phosphate may then lead to increased parathyroid hormone secretion, hyperparathyroidism, because as we discussed in a previous video, calcitriol inhibits PTH secretion. So if there's less calcitriol, there's less inhibition, while phosphate stimulates PTH secretion. So more phosphate, more secretion, stimulation of PTH secretion, and that might be the reasons why we see this increased parathyroid hormone secretion in chronic kidney disease. So the pathophysiology of hypercalcemia in chronic kidney disease is a very complex situation. We could put things in a simple way and come up with a possible scenario. So, for example, there's chronic kidney disease. So there's going to be this impaired kidney function, which means the kidneys will not be able to produce sufficient calcitriol. Without sufficient calcitriol, there's going to be decreased calcium absorption from the GI tract, and that's going to decrease the levels of calcium in the bloodstream. In addition, the low calcitriol, because of the low calcitriol, there is no more inhibition by calcitriol of PTH secretion. So this is going to increase the secretion of PTH. And then we have the inability of the kidneys to excrete phosphate. So there's going to be high concentration of phosphate in the serum. Phosphate is a stimulator of PTH secretion. So the high phosphate or hyperphosphatemia is going to stimulate PTH secretion. So this low calcitriol as well as high phosphate is going to cause increased PTH secretion by the parathyroid glands. So this chronic stimulation of the parathyroid glands is going to cause hyperplasia or hypertrophy of the gland. The gland becomes bigger, the number of cells start increasing in the gland, and this leads to what we call secondary hyperparathyroidism. In this case, you can see the calcium levels are low, but the PTH level is high. Now, the increased PTH levels is going to cause increased bone resorption, and that's going to increase the blood calcium levels. That's going to lead to hypercalcemia. Now, in advanced chronic kidney disease, these parathyroid glands become so overactive that they do not respond to this increased serum calcium. The feedback loop doesn't work anymore, and these cells basically become autonomous. And this leads to what we call tertiary hyperparathyroidism. And in this case, you can see the calcium is elevated, so there is hypercalcemia, and the PTH is also elevated. So in secondary hyperparathyroidism, the calcium is low, but the PTH is elevated. In tertiary hyperparathyroidism, we do have hypercalcemia, calcium is elevated, and the PTH is also elevated. Another cause of hypercalcemia is vitamin D toxicity. In this case, the 1-alpha hydroxylase in the kidneys is very active. For some reason, it's not well regulated, and that will cause the vitamin D to be converted into this active form of vitamin D, calcitriol. And we see this in some cancers such as lymphoma, T-cell leukemia, and in certain granulomatous disorders such as tuberculosis, leprosy, as well as histoplasmosis. Besides these diseases, there's another way to have vitamin D toxicity, and that is just taking excess vitamin D supplements. So that can also lead to vitamin D toxicity. So we discussed the effects of calcitriol in an earlier video. So when you have excess calcitriol in the bloodstream, that's going to increase bone demineralization, and that's going to increase the calcium levels in the blood. Calcitriol will also increase calcium reabsorption from the kidney, and that's also going to cause elevated calcium. And calcitriol increases calcium absorption from the GI tract, and that's also going to increase calcium levels. And these calcium levels will then inhibit PTH secretion. So in this case, calcium is elevated, hypercalcemia, but the PTH level will be low. Another cause of hypercalcemia is immobilization. Prolonged bed rest is going to increase bone resorption due to the lack of weight-bearing stress. So that's why it's very important to move around. So this increased bone resorption, of course, is going to elevate serum calcium, leading to hypercalcemia, which is then going to go to the parathyroid gland and decrease PTH secretion. So once again, the calcium is elevated, hypercalcemia, while the PTH level is low in immobilization. And another cause for hypercalcemia are medications. We'll talk about two medications that cause hypercalcemia. One is the antacids, which are very commonly used and leads to what we call the milk alkali syndrome. And the second are the thiazide diuretics. So we'll leave this for another video because this topic has a lot of interesting connections and applications of biochemistry in medicine. So we'll cover this in the next video. So until the next video, once again, thank you very much for watching and supporting this channel. Have a wonderful day, and we'll see you in the next video.